Thank you so much, Barbara. I totally appreciate the introduction, and I think it shows my ADD more than anything else. I do have a fairly varied career, and hopefully that allows me to bring a diverse and hopefully a comprehensive view of this topic and can answer most of your questions. It's a little aspirational, hoping to bring chaos out of to bring clarity out of chaos, but let's get started and see how well I do. Please let me just share my screen. How's that look? Looks okay? All right. So I think, thank you again for asking me to speak tonight. And I really do hope that we can pull a little bit of clarity out of what I think is often a misunderstood area in terms of palliative care versus hospice and how we help to really support patients and their care partners across the trajectory that defines cognitive impairment. So as Judy likes to say, I have nothing to disclose. And what I'm hoping to do tonight, and please feel free to put your questions or comments in the chat so that Judy and Barbara can take a look at them as we go along, is really to review the difference between palliative care and hospice, because I think this is really critical to understand. Reviewing how palliative care and hospice can help support really a patient, their family, or care partners across that trajectory, and sort of review what are expected clinical changes and symptoms that occur, particularly in later stage dementia, because I know that can be, it's important to understand and appreciate what happens in those months to years and how best to support patients and families at home. And so we begin. So one of the things that I think is important is to really understand the definition of palliative care. And it's really an approach to care for people living with serious illness, all illnesses, cancer, dementia, advanced heart failure, emphysema. And this type of care really focuses on providing relief from the symptoms and stress of serious illness, not only for the patient, family, and care partner, because that's the unit of care that we think about in palliative care. And the goal is to improve the quality of life for everyone in that unit of care. And so I would like to just point out that the word death and dying doesn't show up anywhere in that definition, right? I like to say that every doctor is a palliative care doctor. It's just we care for people differently along the trajectory of illness. And the thing that's really very important about palliative care, which is also true for geriatrics, I'm learning, is it's really foundational in terms of an interdisciplinary approach to care. I mean, all the things we talked about, I am just a doctor. I am just a doctor in this interdisciplinary care team. And more often than not, I am willing to admit, is that I am probably not, nor are your doctors or neurologists, the best person to help you with some of the issues one struggles with during the trajectory of illness. So as a physician, as a nurse practitioner, as a PA, we can certainly help patients with physical symptoms of disease, managing their symptoms, helping improve their functional status. But the other domains of suffering for people with advancing complex illness are psychological, spiritual, and social. And so parts of necessary collaborators for a physician in this space are social workers, spiritual providers, and a whole host of physical therapy. I think I work closely with occupational therapy, the home health teams. It is truly a team sport. And so I'd like to really stress that. And so I like to use this diagram because I really think it helps both visually as I talk, kind of really the difference between palliative care and hospice, because I think that's where a lot of people get tripped up. And frankly, I think a lot of my clinical colleagues struggle with this concept as well. So I think for lay people to understand this is helpful and to appreciate that sometimes we have to educate our clinical care partners as well. So I like to think of palliative care as really that interdisciplinary care team that we talked about that's based on a patient and family's need. And hospice is the small segment of palliative care that's actually a defined insurance benefit that's based on prognosis. So while hospice is sort of part of palliative care for a very specific group of people, palliative care is certainly not necessarily hospice. I hope that's helpful. And so how do we then think about palliative care across the trajectory of disease? I sort of think about it in 3 stages. There's a planning stage, sort of an execution stage, and then a transition stage. And so if we look at this graph, the X and Y axis depict function. And we all know that as dementia progresses, function not only cognitively, but physically starts to change. And that can happen usually with dementia over a period of years. And so at the beginning, around the time of diagnosis, it's important to start planning while you're feeling well. Start thinking about what matters most. What are you hoping for? What are you most worried about? And then the operational things that we never like to think about, estate planning, putting together healthcare proxies. And as we move through the trajectory of disease, there are these ups and downs that might signify a hospitalization, perhaps a trip to the emergency room, perhaps a rehab visit. And during that, all the groundwork that we put together in the planning phase of stage A kind of gets put into place. As the disease progresses and people reach the later stage of disease, the crises that seem to happen at this point really don't have to be crises if we've sort of thought and planned for them along the way. So I'm going to use sort of a short story here to sort of help illustrate what this might look like. So Mr. Smith's a lovely 76-year-old man. He's a retired principal, worked as a principal for years, loved his job. He's a husband, a father of 3, and shares with you during a clinic visit, or at least shared with his provider, that he's had some challenges with short-term memory lately. His wife has actually noticed subtle changes over the past several years and now helps to keep track of appointments and has assumed bill paying after Mr. Smith overlooked paying the bills 1 month. They enjoy going out to yard sales, they love going to Cranes Beach, and they help to take care of the grandkids. So Mr. Smith and Mrs. Smith are really at that stage A, where we need to think about planning. And so one of the most important things for me is really this is the time for those that are going to be living, for those individuals living with cognitive impairment and dementia, to really be thoughtful and name whom they would like to be their healthcare proxy. First of all, I'd like to say that all of us over the age of 18 should have a healthcare proxy. I'm not going to ask for a show of hands, but for those of you that don't have one, now is the time, right? It's just really important. We never know what's going to happen to us. And so it's just really important to have that document at any age after 18. The fact that we don't have them, I think, can be challenging in cases particularly with like cognitive impairment. I think it's important at this stage to really start thinking about financial or estate planning, regardless of how big those assets might be. And I think it's important to take this time to really start working with a social worker, someone like Barbara, reaching out to the Dementia Care Collaborative Group, thinking about what are resources that we should be aware of that we might need in the future, right? Get to know your community resources before you find yourself in a situation where you need them sooner rather than later. So it's like that file of things you put together. And so, as I said, talking with family about things that you're hopeful for, establishing your healthcare proxy, looking into community resources. And these are things that people don't have to dwell on. I think it's like that black box, or it's that playbook that you take down, you put the information in it, and then you can put it back up on the shelf. I think not starting to fill up that playbook can get problematic. And things can then feel a little bit like crises when they do happen further on. If you can't tell, I'm Irish Catholic, and I really do like to have my plan B in place. And so now we sort of move on with our story, and it's several years later, and Mr. Smith would occasionally, or has in the past couple of years, started to leave the house after breakfast when his wife was busy kind of cleaning up, thinking that it was time to go to work, right? School buses would go by. He would think he'd be late for work and would start to leave the house. He's also become slightly unsteady when he walks. He had a fall, and he often forgets to use the cane that his physical therapist recommended he use. He more recently had an episode of choking at dinner. It was a breaded chicken cutlet. They're kind of hard to get down sometimes. And he had a hospital admission for aspiration pneumonia. His eyes continue to light up when the grandchildren visit. And when two of his children can help him get into the car, he seems to enjoy sitting in the car at Cranes Beach and watching the sunset. So I think we're starting to see some of those events that happen as dementia progresses. You know, we're starting to see some physical functional decline. I often say that the swallowing mechanism, as we think about it, is a highly muscular process with different types of muscles actually that have to work in a really concerted, collaborative way. And that's not unusual for people to start to have some difficulty with swallowing. So we're starting to see some of those changes. And so now, as Mr. Smith is experiencing expected clinical changes, some wandering, some falls, some aspiration, it may be at this point that he's unlikely to be able to understand and fully appreciate some complex medical decisions. And so at this point, or for some medical decisions, the team, his doctors, people in the hospital may need to actually collaborate in a shared medical decision way with his healthcare proxy, right? Again, we want to be sure that based on previous conversations of what mattered most, what his hopes were and what his worries were, that we're being more thoughtful of being sure that we're aligning medical interventions with what defines quality of life as we understand it, as related by the healthcare proxy. And so here, where there's increasing reliance, again, on the healthcare proxy, the primary care doc and his neurologist and the hospitalist are all, again, being mindful of the serious illness conversation and what matters most. And at this point, too, I think this is where that you take the playbook off the shelf again and really rely on social workers, care managers, those resources that you'd identified in the future to really provide an extra layer of support. We can also start to bleed a little bit more clinical care into the home, and home health workers such as PT and OT can come to the home and do comprehensive assessments to try to make things as safe as possible for Mr. Smith as he continues to keep as we continue to work to keep his independence. Now, during, one of these hospitalizations, Mr. Smith experienced some delirium, which we know increases as cognitive impairment progresses. And delirium, most people, when they ask about what that is, it can be sort of an agitation or sleepiness that kind of waxes and wanes. And again, this is often seen in patients who are hospitalized, older patients with dementia that are hospitalized. And it can also contribute to an acceleration in the patient's trajectory of dementia. And they can actually take time to resolve, which I think people are surprised about. When someone comes home from a hospitalization, people are worried and uncertain when this delirium takes a while to clear. So it's another expected clinical complication. And so again, as I say, who's the palliative care provider here? It's actually all of us. It's the It's the primary care doctor, it's the neurologist, the hospitalist, and all the home health providers, in addition to the social worker and care management teams. And so now Mr. Smith is 82 years old. He's had a difficult year. He's had another fall and hurt his knee. He went to rehab and had some home PT, although he hasn't really been able to recover much of his function. He now requires assistance to stand and uses the walker to pivot into a wheelchair. As I said, he experienced delirium while hospitalized again for this most recent fall. And again, it's taken a little while to resolve. His cognitive impairment seems to have progressed a bit more quickly again, using fewer words, and he's starting to need assistance with some of his meals. However, he continues to smile when the young children come to visit the house. And so in terms, and this is part of the challenge, I think, with this particular diagnosis, is this more end stage trajectory of illness can either happen very, very quickly, or it can take months to several years to run its course. And I think here I think we all appreciate that having the healthcare proxy is very important, because Mr. Smith is really no longer able to make any decisions. And there are challenges, as I said, related to prognostication and predicting the timing of death, which is one of the challenges with hospice in this space, right? Hospice is a Medicare benefit that requires a prognosis. You wouldn't be clinically surprised if the patient living with the illness died within 6 months. And I think dementia is particularly challenging in that space and can really be hard to time correctly to be able to support the patient and the family adequately. And so let me just talk about the kind of nitty-gritty of the hospice benefit, because sometimes that can be helpful here. So hospice is a Medicare benefit. It's also a benefit with most commercial insurers as well, but in the case of individuals living with dementia, most of those patients are going to be older adults on Medicare. And everyone has the right, who has Medicare, to this benefit. It's probably one of the most comprehensive insurance benefits one can get through Medicare, and it's the one nobody wants to use. So it's kind of like the gold standard, and it's not utilized as much as it could be. And to access that benefit, your provider, your primary care doc, your neurologist really has to estimate that they would not be surprised if the individual with dementia died within the next 6 months. Things that might suggest that that's going to be the case are continued weight loss, worsening difficulties with swallowing, dependence for all care, repeated infections and recurrent fevers are what many hospices will look to really indicate that swallowing mechanism is really a problem at this point, and that combines with the weight loss. And hospice provides care to wherever that individual calls home. So hospice, the hospice team can come to the home and help support the care partner and family to care for the individual with dementia at home. It can be delivered in assisted living, although there's some challenges with assisted living in terms of the care partner support there. And also for people living in nursing homes, the addition of a hospice team can be a great support to the nurses and aides in the nursing home caring for that patient. Some hospices, and this is again some logistics that can get confusing, some hospices own a hospice residence or house where a person can go for different services. So the hospice benefit has a respite benefit of 5 days where a patient can go if, say, a family member needs to go to a wedding or a graduation, and it would not be safe to leave the patient at home, then that patient can go to the hospice residence for 5 days. to be supported and then return home. That is covered by the hospice benefit, as is something called general inpatient level of care if there happen to be intensive symptom issues that have to be managed short term. Most people are on hospice with what they call routine level of care. And so that care is cared for by the patient, but any other care site, such as a nursing home, obviously the assisted living, the hospice residence, the room and board has to be paid for by the family for the patient if they're just on routine level of care. So those are just some words that people may have heard or, have experienced if they've had loved ones on hospice before. But that's the hospice benefit. And as I said, it can be very, very difficult to prognosticate sort of what that 6-month window looks like. But that doesn't mean that palliative care, the concept of palliation can't be delivered to a patient and their care partner at home. So we can craft a hospice-like plan of care at home even before someone kind of falls within that 6-month prognosis, if it aligns with really what the patient and family had hoped for. So the goals of best supportive care, as we've sort of talked about in the management of late stage, really can be done, either inside or outside of the hospice benefit. Obviously, having a hospice team provides a more intensive support, but that doesn't mean that that concept can't still be done in a palliative manner. So the goal really here is to ensure that, for the person living with dementia at this point in their trajectory of life, that we want their lived experience of the present, like every day that they're here, is as comfortable and as high quality as possible, knowing that they really can't remember the recent past and are having, no longer have the ability to sort of conceptualize the future. Like every day, every moment in the presence, how do we preserve that quality of life as best we can? What I often hear from patients earlier in the trajectory of illness and what I hear from care partners towards the more advanced stages is that the ability to remain home, comfortable, and as independent as possible are really the things that matter most to them. And so how do we think then about protecting a patient from burdensome interventions which really may not contribute to quality of life, and in particular in interventions such as resuscitation or intubation, knowing that these things may be suggested when a patient experiences what is really an expected clinical complication and, an event which most of us will actually die from, whether or not we have dementia, infections, pneumonia, advanced heart illness. Hudson didn't like that part of the conversation. So the other thing to be mindful of is how do we think about maximizing the medical management, the medical care of someone living at home? I think part of, at least for us as physicians and also for nurse practitioners, is a lot of our training is not done in the home. Home as a site of care can be an uncomfortable concept for us to get our heads around if we haven't spent much time in the home, because it feels so foreign to us, even though that's where most care is delivered for patients living with dementia. And so how do we think about maximizing that care at home? There are new service lines such as hospital at home. How do we think about increasing the support through home health if there's a need? How do we think about involving a home-based palliative care team as well, so that there are different ways to support people prior to hospice? And we just have to be more mindful, particularly from your perspective, of asking about those things, particularly if your clinicians may not know about all of them in your area. And then symptom management, there's discomfort from Immobility, breathlessness can sometimes be an issue. Again, as we talked about, agitation or confusion if people aren't feeling well, and then just ongoing care of mouth and skin. And so how do we put a team together? Because I think this is really important for individuals living with dementia, and particularly for their care partners, to think about, how do I put the best team together if I can't immediately access hospice? And as we just reviewed, I think really finding a primary care physician or a geriatric provider who's comfortable managing a person who's now become homebound. How do we manage that patient over the phone? How do we manage them via telemedicine, which actually I think is important for many of my colleagues, who then say, I can actually see into the home. It gives them a certain degree of comfort, which then allows them to further be able to keep people at home. Again, I think as some of the community resources that Barbara and Judy are aware of, care managers, either available through primary care offices, through your insurance, or sometimes privately hired, can help navigate and assist with care coordination and identifying resources in the community. Again, we talked about a community or home-based palliative care programs. And really, if goals of care with respect to interventions such as intubation and resuscitation are clear, I always want to be mindful that nobody does something to an individual that they don't want done. And so having a MOLST form in the home can be helpful in preventing confusion in a moment where something may have changed suddenly, and perhaps the person who knows the individual best is out of the home, running an errand. A neighbor or a family member is sort of watching over someone like Mr. Smith and may not be aware of what their wishes are. So I think that can be very helpful too. And so I think it's interesting. There's always a concept of maximizing best supportive care can sometimes feel to people, well, we're not doing everything. And sometimes everything seems as if it should involve a hospitalization or a trip to the ICU. But this was an interesting study that actually Sarah Cooper is one of the authors at the Brigham, and is a surgeon who works in palliative care. And the study really looked at physicians, lawyers, and the general population in terms of where they received care at the end of life. And I found it interesting that physicians were less likely to go to the ICU and less likely to die in the hospital than either group. So either we're planning ahead better because we see expected complications, or we sort of know that at some point, these interventions may actually not improve the quality of our life and may actually contribute to some degree of discomfort. And so to summarize, I love this phrase, the goal is to keep the goal. And it's a quote from a man by the name of Dan John, who's a weight trainer who actually trains older adults to stay strong. I think it's important to remember that along with the definition of palliative care, that palliative care really is this interdisciplinary approach to care. That's the strategy. And that hospice is the insurance benefit, the tactic for a very specific group of people living with dementia. The interdisciplinary team, doctors, nurses, social workers, the home health team, address all aspects of suffering, the physical, the psychosocial, the spiritual, across the trajectory of illness. And that even if a person is not able to access the hospice benefit because that prognostication in that end stage of dementia is really complicated, that the symptoms and complications of late stage dementia can still be managed wherever the patient calls home with the right palliative care team put in place. So I moved through that fairly quickly because I found that there are usually a lot of questions. So I'm going to stop sharing my screen, just because I did want to leave a lot of
Yes.
room for questions.
And you are so right, Dr. Gallagher. There are a lot of important questions.
Excellent.
I think we'll start with just some of the detail ones and then move into the more complex care issues. First of all, as a benefit, is hospice Part A or Part B of Medicare?
Wow. I don't think I have ever
Been asked that?
had that question. That someone must be a billing. So Medicare is Medicare Part A.
Mm-hmm.
So Medicare Part A covers hospitalizations. It covers the rehab benefit, the acute rehab benefit, where you go to a skilled nursing facility. It covers home health. So people cannot have home health, meaning the visiting nurse, PT, OT, at the same time that they would have hospice.
Okay, thank you. A few other detailed questions, but they're really important. It seems that respite care during the palliative care stage is very hard to find.
Yes.
Any tips?
Mm.
And I wonder if this person is referring to respite, well, as in a hospice home, which of course is hospice.
Yeah, no, I think, that's a perfect question, right? Because I think care partners desperately need respite. I think this is probably the challenge of this illness for care partners and family, right? The hospice benefit, definitely recognizing that care partnering can be exhausting, right? And if a care partner needs time for self-care, the hospice benefit obviously recognized that early on and provided for this 5 days of respite. Outside of the hospice benefit, the concept of respite for any care partner is a huge challenge. And there's no insurance benefit for that, right? There, if people have significant needs, respite means arranging for a private paid companion who can stay with someone while the care partner is able to do self-care, go shopping, go away for the day. For Heather and Barbara, you can speak to this too. I mean, for people who have Medicare and Medicaid, people can access PACE programs where there are day programs where people living with dementia can spend the day or two. Senior centers have some senior centers have specialized programs. For the vast majority of us who sort of live in that middle space of insurance or wealth, it really falls to private care companions or Barbara, I'm trying to think of day programs. There are some day programs, but again, they're fees for those.
The other thing I just want to add, which is the overlay to so much of what we're talking about, is we've been living through this small thing called the pandemic. Small, I say that, of course, facetiously. And while the day programs have historically been wonderful resources for the individual with dementia, as well as the care partner who then has respite for 6 or 8 hours a day. Many of those programs closed down during COVID and they're not really reopening. So as you've referenced, Dr. Gallagher, building that care team, creating issues. There are challenges, of course. There's a gap, sadly, I would say as a social worker, more now than in a long time, between what my palliative care colleagues and team knows we hope for a patient's well-being and what we can actually provide, even when there are resources. Would you agree to that, about that?
And Judy, you wanted to add something?
I would also add that if one has means, the continuing care retirement communities or assisted living, you can actually access them for respite care a lot of the time.
Right.
So that's another resource that people can use, especially if you're going away for a few nights or a week or so that the person can actually move in there.
Yeah.
Right. Thank you. Absolutely. You know, Dr. Gallagher, there are a couple of questions that, because you've actually helped us think about thinking ahead. Here are a couple of questions that I'll read to you. What organizations or companies advise families on the best insurance policy for patients with dementia? Hopefully this advice is found before the family members become ill. I'm wondering, because right now now is the time to be signing up for Medicare plans.
Yeah.
And you perhaps are inundated with advice or marketing information from the Medicare Advantage plan. So hold that, which is important. And I think you have referred or answered this, but why don't we start with insurance, because that's a tough one.
Yeah. And to be honest, this is where I turn to my social worker and elder law colleagues, because the insurance market changes so fast and furious, right? You know, United Healthcare is incredibly aggressive, right? By offering, you know, certain dental things but then they don't have this, right? And they have 20 different health plans. I think the plans change so quickly that I can't keep up.
Right.
And I think that's so grossly unfair to this population. And so this is where I turn to someone like Barbara. This is where I turn to our financial advisors at the hospital, you know, for these questions.
And if I can just make one comment, which is to support what you say, you turn to me and I turn to, you know, my place to scream, the reality that I think is important for all of us to name, because I'm sure every one of you has experienced it. What the universe of healthcare, of insurance, even of Medicare, does not yet fully acknowledge in terms of the tragedy of brain disease to an individual is that care that is needed is serious life-saving care. But the way that insurance pays for care is this difference, and maybe you could speak to it, Dr. Gallagher, between skilled and custodial.
Yes.
So if I as a person with dementia, that lovely man, can't be alone at all during the day because I forget to use my cane and I fall or I wander, will Medicare pay for an aid for me? No. Could you speak to that? Because that's what is so confusing about all insurance. Judy.
Can I give just one suggestion for a really good resource to know which health plan to purchase through Medicare is the SHINE program.
Right.
And you can look up you can go right on the state's website and get that, or just email any one of us, SHINE, SHINE. And really
there was some hand waving, like, yes, that was helpful in the past. Or not, maybe, I don't know, maybe I misunderstand.
Yeah, well, and it's a mixed bag, because they have been amazing. And since COVID, some people have told me that when they've spoken to SHINE, the SHINE workers have left. So it is all a mixed bag, but feel free, I invite you to email me in our program. So Dr. Gallagher, but speak to the challenge of acute care, custodial care.
Yeah. Oh, geez, that's a whole nother talk right there. You know, our healthcare system is really based on responding to acute care, right? Hospitals are great, but it's an acute episode of care. your PCP follows you longitudinally and does, preventative care, and then you go to see them for urgent visits. This is the challenge with care that's really, it's so, the word custodial is so interesting to me. I think it's the word we have, and yet I think it's really just dignity care is how but no one knows what I'm saying when I say that. But I really think it's personal physical care to preserve dignity. That is incredibly hard work and is not covered by any insurance unless you have Medicare, Medicaid, right?
Yeah.
So for those of us that, don't have that as an option, that's why skilled nursing facilities, when that decision is made, that's why advanced planning is very important in terms of thinking about assets, is how to structure one's asset profile, regardless of how big or small that is, to allow the person as they progress through dementia to be able to access perhaps Medicaid if needed, to be able to access long-term care in a skilled nursing facility without depleting all of the family's assets, if that's needed.
Great. I'm going to ask one more resource question and then go into some very important clinical questions, which I know are important to everyone. You did mention that providing palliative care in assisted living facilities can sometimes be difficult. And the question is, what are the challenges at assisted living facilities?
Right. So I think palliative care is easier than hospice. If we think about hospice, and it's probably, I should actually rephrase that as, I think care of the person with advanced illness as the disease, any disease progresses to late stages, can be complicated if there is not a care partner. So the challenges with assisted living for those who have friends that live there or might live there themselves is that things like medications, like who is there to help with the caregiving, because the assisted livings aren't really nursing facilities. There aren't people or aides that can give medications or do symptom assessments if there is not a care partner that lives with the patient or individual that we're trying to care for. So I think some of my most challenging situations as a hospice medical director were really individuals living as an individual in an assisted living with no care partner in the apartment. That's the situation that really one cannot care for that individual in an assisted living, because it's just assisted living. It's not, full dignity care, right?
Thank you. Now, a very important question, which takes us into health decisions. What if a patient living with dementia decides he or she didn't want to eat? They can swallow, but simply refuse to eat.
Mm-hmm. So that's a interesting question. I actually heard that. I had someone ask me about that today. So that's called voluntary declining of eating and drinking. And it's interesting. There are two ways to think about this: is either someone has mild to moderate or moderate dementia and chooses not to eat. Although I don't often see that with dementia, that's in the late stages, because that requires kind of conceptualizing that I'm not going to be doing that, right? So the kind of concept of voluntarily not eating or drinking is something that really doesn't happen in moderate to severe dementia, that voluntary component. It is not unusual, however, to see people with moderate or more advanced stage dementia not want to eat, right? I don't think we fully understand why. I think we have to be sure that there's not some undiagnosed anxiety or depression that's going untreated, because that's, not wanting to eat is a sign of both of those complications. But there is an apathy that can't be medically treated with medication that can often be seen with neurodegenerative diseases such as dementia. And that's very hard, right? Particularly for some cultures, but for all of us, when our loved one really doesn't have an interest in eating or drinking, whether, in late stages often isn't voluntary, they just don't. We assume that they don't have an appetite, that they don't have the interest in eating. And what I suggest to people is like, well, if you find that they like certain foods over others, provide that in very small amounts just to keep the taste in their mouths, since that's what they might enjoy. But we also want to be mindful of not feeding too quickly or feeding too much, because the swallowing mechanism can sometimes start to break down. So I think that's hard to hold for people, right? Because we sometimes define caring by feeding or helping to assist to feed. And that can be hard to sit with. But as best as we can ascertain, people aren't uncomfortable or hungry and just aren't able to eat. It seems to be more apathy in that case. Is that fair to say, Barbara?
Yeah. And I think that one of the things that I've heard geriatricians and neurologists talk with families about is there a way to identify or distinguish in late stage dementia apathy from clinical depression? Is apathy part of the progression and there's no medication to treat? Not that we ever want to reverse. We know we're looking at symptom management and comfort. Is if someone is suddenly not eating and it's sudden rather than apathy, if there's a depression, might that be something you as a palliative care physician would say, let's try a mild antidepressant, but just to help with eating. We're not looking for the big cure.
Yeah. I mean, there is no cure. And so if something happens suddenly or more quickly than I would expect with a traditional trajectory, although some people that have small strokes can have these step downs, I think it's always incumbent upon us as clinicians to run through what we call our differential diagnosis. If something happens that we weren't quite expecting, maybe dentures aren't fitting, maybe there's a mouth sore, maybe people have a, fungal infection in the back of their throat. I have to say, if, I had a quarter for every time that constipation was the problem, I'd be a wealthy woman. There's simple things that aren't so simple, right? That working in an interdisciplinary team, particularly with my hospice nurses as a hospice medical director, I learned just so much from the bedside perspective of the nurses and the home health aides. The home health aides used to just kick my butt when I did things wrong. So
that's why it's so wonderful to work with you, because you welcome everyone. And another important medical issue, what's the thought of late stage dementia with many of the progressive symptoms in patients with pacemakers? So I think that's the larger question about when might I be thinking differently about recommendations the doctor has, be it a pacemaker, mammogram, colonoscopy. How do I think about some of that with my person with dementia?
Absolutely. How I think about things like cancer screening really is, what is the time to benefit of cancer screening? And it's usually measured on the order of years, right? There's a wonderful website called Geripal, right? That has actually on it, I think it's available to lay people. It's called the Geripal. And I will find that for Judy and Barbara, or Barbara, Judy, maybe you could look for it. But it has something on that cancer screening. And it really does a nice visual of saying, put in these patient factors. And if we're looking at colonoscopy or looking at mammogram, what's really the time to benefit? And for me, I always really just go back as, how is this going to impact this patient's lived experience today? Like, if the benefit isn't going to be for several years and we're focusing on making every day a good day, a colonoscopy is not a good day, right? A mammogram that's not understood by someone is probably not, that's not the time to do it. Pacemakers and ICDs, or the shocking component of the pacemaker, are interesting questions, right? So if a patient has, or if an individual has a defibrillator, an ICD, and between what they had stated mattered most and what the healthcare proxy's understanding of that, they may reach a point even before that terminal component, that terminal stage, that, I really don't want to be shocked. Like, if I can't recognize family or friends, or I can't do these things, then anything, the pacemaker will fire when there's an unstable heart rhythm that could lead quickly to death. In most people, excuse me, most people will say, I would like to die quickly and painlessly. And so I've had people say, look, my defibrillator was great when I was playing golf. The minute I can't play golf, or, for that person, or the minute I can't do something else, I don't want the pacemaker, I don't want the defibrillator firing at that moment. And so that's a conversation of deactivating the defibrillator, depending on where a person is in the stage of disease. A pacemaker is a different question. So what I say, is the pacemaker really supporting the function of the heart? Like, if some people have these things called heart block, where the pacemaker is essentially prompting the heart to beat in a regular fashion, stopping that is sort of a discontinuation of that intervention, and that may not be indicated, right? I find that if pacemakers are there because people have erratic or pauses in their heartbeats, and that the pacemaker is preventing falls that might happen during moments of pause, right? Because if the heart pauses, you're not getting enough blood to your head, you tend to fall or syncopize, right? We don't want people to fall if we can prevent it. So that's how I think about a pacemaker in that case. So it really kind of ends up thinking about, what's the indication and what is this helping to prevent? So I find pacemaker discontinuation, it's individualized. I don't think about that as frequently, because it's not, I think stopping it sometimes can be lead to a complication that we could avoid otherwise. But I think a defibrillator is a different discussion. And I think turning those off, certainly when we've reached an end stage or bedbound situation, makes a lot of sense.
That's great. Dr. Gallagher, we have a good amount of questions, for good reason, about people who want to search for that right combination of care providers, and we'll get to them all. Arthur asks or says, we attempted to institute palliative care earlier this year with mom's PCP and a home health agency that was seeing her after a troubling hospitalization. However, both the PCP and home health agency said she didn't qualify, quote unquote. However, this doesn't make sense.
No.
Are they confusing palliative care with hospice? How do you get the PCP on board with palliative care? And then, quote, mom cannot easily change PCPs because of her insurance situation. So Dr. Gallagher, short of paging you at 3 a.m., it's a very profound and important question. Yeah.
And that's not a 3 a.m. That's the playbook question.
Oh, okay. That's the playbook.
I have to say, this is a struggle, right? It sounds, Arthur, like, your mom's PCP has had her as a patient for years, right? And it's interesting in looking at studies that the people who overestimate prognosis by a factor of five, right? 5 times they overestimate someone's prognosis are those that have the longest relationships with patients, right? It's not unusual, right? These are the patients we love, the patients we care for, that we've established these relationships, we've seen them over time. It's interesting. I totally respect my primary care colleagues for their great care, and they struggle. They struggle with the concept of supporting patients through some of these transitions. It feels hard for them too, which is I find that touching and should be reassuring for you, although it can be then complicating because you like to have someone more of an advocate along that type of care. But I think what the confusion, Arthur, may be there, and I think we see it often, is that primary care docs continue to confuse, through no faults of their own, because the percentage of patients that they manage on hospice or palliative care is small relative to their overall patient panel, right? Is that the providers are probably confusing what you're asking for. They may think you're asking for hospice and you're really looking for home-based palliative care. The agency may not have a home-based palliative care provider, and therefore the home health agency may only be able to offer you hospice, which your mother may not qualify for. So this is the challenge, right? And sometimes home health agencies may only offer a palliative care nurse practitioner to patients who are on hospice, who are on their service as part of Medicaid Part A skilled, like nursing, PT, OT. So it drives you just crazy, right? It's like insurance, because one agency will do one thing, one agency won't do another, and then everyone's confused about what hospice and palliative care are, right? It is crazy making for you all, right?
And that's why we have you come back every year.
I just happen to do it all the time, right?
But you see, it's also very helpful. I find validating to hear from our supreme expert that it is a crazy making system. I mean, I often want to tell families that what I'm trying to help you navigate isn't necessarily a logical system.
No.
Because if you look for logic, you won't find it. That's why
Yeah. But there's another thing here that I think is can be useful, right? To be, it does feel a little odd for you as care partners, as patients, as family, to try to help support, your clinical colleagues take care of you and your family. I often will say to PCPs when I've seen a patient in the hospital, or talking about their patient panels in terms of who home-based palliative care can help, and they all say they're often not ready, which means that maybe the provider's not ready. But one thing you could say, or could say any of you, but Arthur in particular, if it's hard to get mom into the clinic for visits, is just saying, it would be nice to be able to have someone to be able to come to the house, to be able to be your eyes and ears in the home, because I know you're not seeing mom as often as you would like. And she may, that person may be able to help you, maximize care with more frequent visits.
Now, that brings me to a question that I think will help all of us, and certainly will help me. And you make, when we're talking about a primary care doctor who has known my mother for years,
Right.
And if she does accept a referral, to make a referral to home-based palliative care team. So my question is, what is the interface of primary care doc, cardiologist, everyone, and the home-based team? If I accept home-based, do I lose my primary? Could you speak to that?
Yeah. So this is the confusion between palliative care and hospice again, right? Is people think when they transition to hospice that they can't see their doctors anymore, right? This is hospice, right, that we're talking about right now. So hospice is Medicare Part A. It is not Medicare Part B, which the cardiologist, the PCP, all these people bill Medicare Part B when you see them, right? Now, when a patient's on hospice, it doesn't mean that they can't go into clinic, right, and see the doctor. But often most people can't make it into clinic. Although I used to care for a lot of people that would go like to their cottage in New Hampshire, which we often encourage, right? The problem is when you go into clinics to see doctors, they often order a lot of tests and things, which, you know, may or may not help with symptom management, but cost a whole boatload of money. And hospice gets paid about $150 a day to be able to get you a nurse, to get you a home health aide, to get their social worker, to get their chaplain, right? It's a very fixed amount of money. So if you order a TSH, like a thyroid test, that test costs $220. So just to put all of that into perspective. So hospices get nervous when you go to the doctor's office because the cardiologist, if you're on for end-stage heart disease, is going to order several $1,000s worth of lab tests, right? Which they have to pay for if you're on hospice for end-stage heart disease, right? It gets weird, right? That's not to say that labs can't be drawn. They just have to be drawn thoughtfully. And sometimes it doesn't even make a difference what the number is, right? Like, how do you look clinically? For palliative care, I want you to think about home-based palliative care. It's not an insurance program like hospice with all those Medicare, Part A things. Home-based palliative care is basically a palliative care clinic on wheels. It's like going to the cardiologist, it's going to the pulmonologist, they bill Medicare Part B, you may or may not have a copay. It's like going to see any subspecialist. So they sit with you in the home. And as I say, when we sit with you in the home, we experience all the craziness of multiple care providers. And sometimes that home-based palliative care person can be helpful in helping to coordinate some of that care and prioritize it. Because sometimes it can be overwhelming to have to go to multiple providers if what they're telling you, everything looks great, I'll see you again in 3 or 6 months, right? It's a drive into MGH, or it's a drive into the Brigham, or it's a drive into Newton Wellesley. It's, it can be exhausting. You want to spend your time, going to Cranes Beach. Who the heck wants to sit in a waiting room, right? So you have to look at maximizing each interface with the healthcare system. And make every day count.
So therefore, if I refer someone who lives in Cambridge to the home-based palliative care team, who also has a geriatrician here at Mass General, the geriatrician remains the primary care doctor.
Absolutely.
And consults with the home-based palliative care team. That's great.
Yeah. So the home-based palliative care team is a consulting team.
Perfect.
They take over your care. Yeah.
Great. A couple of important questions and an opinion about, who does what care. One important question from Charles is, what do home health aides and certified nurse assistants need to know about caring for dementia patients, especially in the area of mental and emotional preparation? And I just want to read one comment from Jim, who thinks a lot about, as you do, operations and systems. He says we need to think about domicile care outside the healthcare system. Trained people can take care of folks and recognize impending clinical events without a healthcare structure like the hospital. However, the domicile staff, and I think that's really the aides and the personal care assistants, they need to be able to monitor stable clinical issues and be trained. So that's someone who is saying it is possible, like maybe assisted livings can do more, but the training isn't necessarily there. Do you want to respond to both? Have I added too much together?
No, I think it's interesting. I mean, assisted livings, I sort of think about them as like college dorms for adults.
Yeah.
You've got your dining services and kind of your nurse's office, but they really aren't facilities in which care, right, clinical care, medical care is provided, right? They provide some home health aid time, can help with bathing, getting dressed. They can hand you medications, but you have to be able to take them yourself. So they're really not sites of clinical or medical care. They're slightly supportive, but they really depend on you being fairly independent still, unless you have a strong care partner that's going to provide all that other dignity care, right? And yes, I think, home health aides, companions are extremely important. And caring for someone with neurodegenerative disease, particularly dementias, requires a little extra training, right? I think it's really important to how to manage someone who doesn't, struggles to understand why you're asking them to do something, how to learn to reapproach, how to not, challenge. I think there is an incredible amount of skill actually that goes into providing care for folks with dementia. It's very specialized, right?
Yeah, and that's when, if you are someone who's looking to hire privately, for example, an aide, or working with one of the elder service agencies, it's helpful to ask the question, is the aide who's coming, are these people who have specialized dementia training, as opposed to being very skilled in caring for people who are in bed and needing personal care. You've done such a good job at wanting us to have palliative care for the people we care about, that there's a request for some clarification.
Sure.
And I'll read these two questions these few questions to you.
I think I was scanning those, Barbara, and I was like,
okay.
So, the community-based or home-based palliative care teams, go to assisted livings, to the independent living side of that, to the memory care unit. They're the same people that are coming. And let me see, there was one other one. It was really the memory care unit. And they are often the same, can be coming from the same agencies or healthcare systems that are doing home-based care, right? So home-based clinicians, community-based, that's why I sometimes use the term community-based, not in the hospital or not in the clinic. So community-based teams will go to the home, go to assisted living, go to memory care units. They don't, and some will go to SNFs, right? So you have to be credentialed to go to a skilled nursing facility. What gets confusing, as I said before, is that some of these community-based palliative care nurse practitioners or teams that are associated with home health agencies, sometimes those agencies will provide the palliative care visit only while the patient is on service for them for like home health. And when the home health episode of care ends, right, like your skilled nursing, you don't need that help anymore. You graduated from physical therapy. When you're discharged from home health, the palliative care piece goes with it. So not everyone has a community-based palliative care team that can see people outside of, their home health episode of care. It's just, it's a tough.
Yes.
It's tough to pay those clinicians when it's not a huge reimbursement stream for them, to be honest.
Kathy offers a clarification to people which is, I think, indicative of the system.
Yeah.
The confusion with assisted living is that some of them do have nurses on staff and additional services at a cost. For example, for medication management, the lines become very blurred on what medical care they provide. And that's true.
Yeah, it's true, Kathy. And actually, to be licensed as an assisted living, you do have to have a nurse on staff, but the nurse can't actually do nursing. Right. Sometimes they have weight checks, sometimes they'll check blood pressures, but the nurse can't actually practice nursing.
Okay. And here's a good technical question. Is an order from PCP required to access palliative care from a home-based palliative care team/agency?
Let's just go with yes. Yeah.
Okay. What about a patient that is currently in assisted living and wants to stay to the end because it's her home?
Yeah.
Is there a time that the assisted living steps in and says that this is no longer feasible, that she cannot stay any longer due to, care issues, difficulty walking?
Yeah, I think that's a great question, and it's hard, right? Just like everything, if you've seen or lived in one assisted living, you've seen and lived in one assisted living, right?
Yeah.
What I would say is, as a general rule, assisted livings will ask an individual to leave really if they're really hard pressed to do that. However, if an individual has difficulty walking or needs help getting in and out of bed or requires a wheelchair, that's fine, as long as there is a care partner, a wife, a husband, someone who's living with that person who can be there all the time to provide that care, right?
Yeah. Now, this is a focus question, Dr. Gallagher. I don't know if you have any thoughts on Medicaid, not Medicare, Medicaid's in-home care program. I'm concerned about signing my mother up for it, especially given the overall lack of help everywhere and the qualifications of the in-home caregivers.
So the Medicaid, Medicaid has a number of wonderful programs.
Right.
There's the foster care program, the PCA program. What I would say is everything is worth a try, right? There are so many good caregivers out there, so many skilled people, and there are some that are trying to get better, but may not have a lot of training and support, but really want to get better. But if you have access to anyone who can be a caregiver in the home, even for short periods of time, I think it's worth trying it. And, you can always ask for someone else to come to the home if there's a challenge, understanding that might not be possible, but.
Great. There are two related questions. By the way, we have about 5 more minutes. So if anyone else wants to add their questions or comments, please do. There are 2 good questions about essentially, where do I find a social worker? How do I start? The one question is, we were told that social workers are valuable when you're ready to look at assisted living, but what other times can they help? Understanding we need a referral. Do we need a referral from a PCP for social worker? Should we engage with one now and build a relationship? I'm going to just give you the other question, which is close, and someone else is acknowledging and asking, where does one find a relevant social worker who can help with all these different facets of the healthcare system? Is it through the hospital, the PCP practice group, or the state? So where do I find one?
Barbara?
Okay, all right, well, thank you. Have you just set me up? Okay, you have.
Oh yeah, you want me to answer that question? I'm just a doctor. Good
okay.
gracious.
So a number of things for those of you, and of course there isn't one answer. If there only were, but here's the thing: for those of you whose relatives are in PCP practice, like at Mass General, for example, yes, you check with the primary care practice, because each practice and the differences are vast and varied. They may have a case manager. They may have what we call at Mass General an ICMP social worker. That's a social worker assigned to patients who meet certain risk criteria. So number one, first call the practice, the medical practice of your relative, and ask if you have on-site a case manager or social worker available to your parent or spouse. If not, if there's an active nurse there or nurse practitioner whom you're comfortable speaking with, or you often call when you have a question, ask if she or he can recommend either a particular community social worker or, as Dr. Gallagher mentioned, geriatric care managers. Now, they are excellent specialists, though they do charge a fee for their work. And it could be as much as $150 to $200 an hour. I want to say this, however, an excellent, like everything, an excellent elder care attorney that Dr. Gallagher recommended can help you immensely, and it need not be 6 months of care. An excellent, I know Judy Willett knows many, an excellent geriatric care manager. You can ask for an initial assessment. You're not signing a contract for 3 years. You might be able to get someone, might want to hire someone to come do a home assessment and help you begin the navigation. So there are many ways to do it.
And what I would say too is that many people will have periods of, the VNA come to the house, right? Every VNA has a social worker. So whenever you get skilled nursing, whenever you get PT, ask to see the home health social worker, right? Who can be a great source of, just say we need some help planning for the future. We really would like some, to better define community resources. And also, some of the Medicare Advantage plans, some of the Medicare supplemental plans, some of the commercial plans that folks are on are very vested in trying to help you find supports to maximize care at home. So call your insurance company too, and see if they have a social worker or case manager who can be helpful in identifying resources. And then, social workers do different things. I mean, I think Barbara, from her work, the social worker I work with in the home-based palliative care service, they work they really work on kind of the spiritual and existential and the, pre-bereavement that can often accompany dementia. And then there's some social workers where their skill is task oriented in finding and identifying resources for you. So it's good to know that there are all different types of focus for social workers.
Dr. Gallagher, in finishing this really important hour and a half, which went so fast, it occurs to me that maybe we can end on, because as you've been giving advice and responding, and we've been talking about, you see one assisted living, you see one, and palliative, maybe we can end on summarizing the questions we want our viewers to keep in their minds, because it's really the question you ask of your insurance company, of your PCP, of the social worker who comes in from the hospice. There are all these people who come up. Maybe we can just end with, what are the 5 most important questions that I ask everyone who comes near my relative, in terms of asking them to define their role? I would start with, will you interface with my relative's primary care doctor? I mean, Dr. Gallagher has told us the answer, but you want to know, right? If it's a social worker, I want you to ask, when do you stop coming? How far can you take me? See, I think that's what I'm most struck by now. You can have, by the end of a hospitalization and a rehab stay, you might have cards for 3 different social workers, but everybody stops and starts at different times. So I'll end with my advice, and if you want to have yours, which is, anytime someone says, I'm your social worker, I'm your nurse, ask, where does your role stop and start? Do you think that's a good place to?
That's a great, and Barbara, I never really thought about that, but you're absolutely right. It gets confusing because you do end up with stacks of cards, and, the social worker in the hospital could have been absolutely great and helpful, but they're they start and stop at the hospital doors, right? Yeah, I think it's important to focus on really what matters most, right? The goal is to keep the goal, and really trying to find those team members who can keep focused on the goal and making decisions regarding interventions, community-based resources that really align with furthering that goal at a very challenging time, right?
And that's an absolutely elegant, eloquent, and important place to end, where you began. And I, for one, am always learning when I hear from you. And I've had the honor of hearing you speak a number of times. You teach, you're warm, you're empathic, you're just amazing. And on behalf of everyone, we thank you. And I'm going to ask Judy Willett to close out the program with a mention of evaluations, slides, and our next program in November. But Dr. Gallagher, we are so grateful to you.
Thank you very much. Happy
Thank you so
to,
much. I
happy
also
to answer
love-
any other questions that may come through the chat, or that you guys may, get that can't answer, but usually the two of you manage to answer most of them. So.
Thank you
Thank
so
you.
much.